Hello, this is Dr. Jennifer Klemek-Yangling. For this lecture, we're going to talk about pediatric GI and nutrition. A recent big change in pediatric nutritional guidelines and nutritional guidelines in general is that they flipped the old food pyramid, and what you're seeing out there is the new inverted pyramid that places more emphasis on protein, healthy fats, vegetables, whole grains, and limiting ultra-processed foods. Keep in mind with pediatric nutritional guidelines, if you look at the AANP and the CDC, for infants birth to 12 months, 0 to 6, recommended is exclusive breastfeeding. If not breastfed, the infant should be given iron fortified formula. They do not recommend any water, juice, or solid foods, and vitamin D, 400 units per day if breastfed, or less than 1 liter of formula per day. In infants 6 to 12 months, it's recommended to continue breast milk or formula and introduce solids at approximately 6 months or when the child is developmentally ready. You want to start with iron-rich foods. That includes usually what they start with is the fortified cereal and then meats later. It's recommended that you introduce allergenic foods, peanut, egg, early if appropriate, and you want to introduce one new food every 3 to 5 days to look for any allergies. In this age group, you want to avoid honey, cow's milk as a main drink, added sugars, or juice. Toddlers ages 1 to 3, you're going to transition to whole milk at about 12 months. You want to limit this to about 16 to 24 ounces per day. You want to try to make sure that the diet is balanced from all the food groups, taking into consideration the new inverted pyramid. You want to encourage fruits, vegetables, whole grains, and lean protein. Juice, they like to limit that to less than 4 ounces per day, and to avoid if you can. And then at this 12 months, you're going to screen for iron deficiency anemia. Preschoolers, school-age kids, ages 4 to 8, you want to have 3 meals and 1 to 2 healthy snacks per day. Again, emphasizing fruits and vegetables, a variety of them, whole grains, low-fat dairy after age 2, and lean protein. You want to limit sugar-sweetened beverages and processed food, encourage family meals, and you want to encourage your parents to have the children participate in a physical activity more than 60 minutes per day. Older children and adults, 9 to 18 years, they're going to have an increased caloric and protein needs due to their growth spurts. And believe me, that's a true story. I raised 3 young men, and I couldn't keep food in my house because they felt like bottomless pits. Key nutrients at this age, your vitamin D and calcium for bone health, iron, especially in your menstruating females, and protein. At this age group, you want to have them drinking low-fat or skim milk. Encourage regular meals, including breakfast. That can be a bit of a challenge with your teenagers. And you want to be sure at your yearly visits that you're screening for obesity, eating disorders, and food insecurity. So just some high yield and board pearls, no cow milk before age 12, no honey before 12 months. That's because of a botulism risk. Juice is not required at any age. Whole milk until age 2, then low fat. Early allergen introduction is safe and recommended at this time. Vitamin D supplementation is routine in infancy, and you want to make sure that you're screening for food insecurity. And if that's the case, you may want to have some information for your parents about WIC and SNAP benefits as needed. One of the biggest changes that has happened recently is, and I'm sure you've seen it all over the different recommendations, is how they are introducing the new inverted pyramid. And this is placing more emphasis on protein and healthy fats than fruits and vegetables, whole grains and legumes, and then to limit ultra-processed foods for all individuals, but this also pertains to the pediatric population. So I'd like to talk a little bit about some of the pediatric nutritional guidelines that are aligned with the AAP and CDC. So infants birth to 12 months, we'll start with 0 to 6 months, exclusive breastfeeding is recommended. If the infant is not breastfed, you should recommend an iron fortified formula. No water, juice, or solid foods. And for infants 12 or 6 to 12 months, continue the breast milk or formula. Around 6 months, you're going to introduce solids or when they're developmentally ready. And you want to start with iron-rich foods. And you're thinking, am I going to give this kid a steak? Absolutely not. You're going to use fortified cereal. There is a new mindset about introducing allergenic foods, your egg, your peanut, early if appropriate. And you want to give anticipatory guidance to your parents that you want to start one new food about every 3 to 5 days. So if there is an allergy, you can kind of pair out what caused it. Because if you give them 3 new foods and they break out in hives, it's going to be hard to decide what exactly caused the reaction. In this age group, you want to avoid honey, cow's milk as a main drink, added sugars, and juice. Toddlers, this is ages 1 to 3. You're going to transition to whole milk at around 12 months. You want to limit this to 16 to 24 ounces per day. You want to try to have a balanced diet from all food groups. For those of you that are parents, you know this can be a bit of a challenge as toddlers can be a little bit fussy about their food. But you want to encourage your parents to give a variety of foods, fruits, vegetables, whole grains, and lean protein. Juice is not recommended, and if the child is going to have juice, you want to have less than 4 ounces per day. And around 12 months, you're going to screen for iron deficiency anemia. Preschool and school age kids, ages 4 to 8, you would like to see them eating about 3 meals a day with 1 to 2 healthy snacks. You want to emphasize with these kids fruits and vegetables and a variety of them, whole grains, low-fat dairy after the age of 2, and lean protein. You want to limit sugar-sweetened beverages and processed food as best you can. Encourage family meals. And in this age group, physical activity, you do like to see these kids having more than 60 minutes of activity per day. Older children and adolescents, 9 to 18 years, they're going to have increased caloric and protein needed during growth spurts especially. I raised 3 boys, and this was never so true as they were going through their growth spurts. You couldn't keep them full of food, my kitchen full of food. Some of the key nutrients that you want to pay attention to, your calcium and vitamin D. This is important for bone health. Iron, especially in your menstruating adolescents, and protein. At this age, you want to encourage low-fat or skim milk. You want to encourage regular meals. With teenagers, sometimes it can be really hard to have them eat breakfast, but as we know, this is one of the most important meals of the day. At each visit, you want to screen for obesity, eating disorders, and food insecurity. Couple of important things for boards and wards: no cow's milk before age 12, no honey before 12 months. This is due to a botulism risk. Juice is not required at any age. Whole milk until age 2, and then low fat. Early allergen introduction is safe and recommended. Vitamin D supplementation, we're going to talk about that at the next slide. And you want to be sure that you're screening for food insecurity in individuals that are, and this is a problem, and it doesn't discriminate. You want to be able to and be prepared to refer these individuals to WIC, SNAP benefits, food pantries in your area. So make sure you're paying attention to that as you're in your clinical settings. Vitamin D. So vitamin D is important to build strong bones and prevent rickets. Rickets is a conditioning of the softening of the bones, and this can happen in growing children. We also know that, especially here in the Northeast, we don't get enough sunshine, and we know that vitamin D helps with bone health as well as there's some benefits for the mood. All children need vitamin D beginning shortly after birth. And in children younger than 12 months, they need about 400 international units of vitamin D each day. And children 12 to 24 months need 600 international units of vitamin D each day. Now, what we do know is that breast milk doesn't provide all the vitamin D a baby needs. So babies who are fed only breast milk, or who receive both breast milk and infant formula need to have supplement with 400 international units of vitamin D every day. Now, for infants that receive only infant formula, vitamin D supplementation is not needed because we know that infant formulas are fortified with vitamin D. For children who have started to eat solid foods, it's important that the children's diet has some foods with vitamin D, and that's some fish like salmon or light canned tuna, eggs, plain cow's milk for children 12 months and older, yogurt, cereals. So that's some things to think about with vitamin D. Talking a little bit about formula and some of the types and when to use them. Standard cow's milk based formula, to keep in mind that the protein that is used is intact cow's milk protein. There's lactulose, there's usually vegetable oils in there, and we use this for the majority of infants. Now, partially hydrolyzed formula, this is where the protein is partially broken down, and some of the names are Gentle Ease, Comfort. They will use this often with kids that have mild gas, fussiness not related to an allergy. This formula is not appropriate for a child with cow's milk protein allergy. So extensively hydrolyzed formula, this is where the protein is broken into small little peptides. And this is the Nutrimogen or Alimentum, extremely expensive. It's the hyperallergenic, they'll call it, formula. And this is used for children with cow's milk, a protein allergy, severe eczema, a child that presents with blood-streaked stools as well. And then they also have soy formula, and that's your Similac, your Isomil, and this it's indicated with children, especially if the parents have a preference for vegan, hereditary lactase deficiency as well. It is not recommended for the cow milk protein allergy, and you may see this as CMPA in some of your readings, so just keep that in mind. And then they also have some other types of formula, the lactose-free, the anti-reflux, and then they may have like the premature infant formula that's got the higher calories for kids that are preterm or low birth weight. So some pearls for this: no cow's milk before 12 months. You do not want to have the parents dilute the formula. This can cause, provide a risk for hyponatremia. You'll have some parents talk about homemade formula. That's discouraged. And again, no honey at ages less than 12 months. So iron-rich foods, the classic ones: meat and eggs, seafood. Remember that vegetables do have iron as well. You want to sometimes add a little bit of vitamin C for it to help with absorption. That's why we tell pregnant women to take their prenatal vitamins with a little bit of orange juice. So vegetables: spinach, broccoli, sweet potatoes, peas, your greens, kale. Often with breads and cereals, they are enriched. So, your enriched pastas, your white bread, enriched rice, fruits, strawberries, watermelon, raisins, dates, prunes, dried apricots, and peaches. But keep in mind, for your families that are vegan, you want to really lean into the beans and tofu. So beans, you think about the kidney beans, garbanzo, white canned, your tomato products, dried peas, lentils, your instant breakfasts, and tofu. Infantile colic. The symptoms that present are intense, unexplained crying, often in the evenings. The kids may have some stiff limbs, clenched fists, they've arched their back. They may have a swollen tummy. They'll often things will be relieved by passing gas. But with these kids, there's no fever or illness present, and generally there isn't any failure to thrive. Usually it's defined by the rule of threes: 3 hours of crying every day, 3+ days per week for 3+ weeks in a healthy baby. And this will often start around 2 to 3 weeks of age, peak around 6 weeks, and then typically resolve around 3 to 4 months. This can be extremely, extremely distressing to the parents. You're going to be giving a lot of anticipatory guidance for these parents because they get really super upset. They're exhausted. And this is a time that can, you have to really screen for child abuse and make sure that there's some things in place to help these parents out. I mean, you need to emphasize that they need to take breaks, that there needs to be a safe place for them to put their baby down. For example, if they're crying, they can't console them, to put them safely in their cribs for a few minutes and take some deep breaths. These kids are at risk for shaken baby syndrome. You may want to discuss with the parent, maybe some additional help from another caregiver or family member or friend. Sometimes, you can, explain to them, they motion and sound, gently rock, use the baby swing, go for a walk with the stroller. Sometimes sound, the white noise. Kids sometimes like the vacuum, soft music, and then maybe give the baby a warm bath, swaddle the baby, or hold them tummy down across your knees with gentle back rubs. You may discuss hydrolyzed formulas. You may, if the mother is breastfeeding, some of the things that can cause some problems are, if they're eating cabbage, Brussels sprouts, onions, garlic, these type of things can pass through the breast milk and cause the baby to have some gastrointestinal duress. And you want to make sure that they're, doing good burping. They will try all different bottles and this type of thing. So with colic, you want to give a lot of anticipatory guidance. You want to reassure the parent. And this can be a real difficult time for your young and new parents. Dysphagia. Dysphagia is difficulty swallowing solids, liquids, or both. Odonophagia is difficulty swallowing. You may have a globus sensation. This is a lump in the throat without true dysphagia. There's a couple types of dysphagia. There's oropharyngeal, which is transfer dysphagia, which has to do with the mouth and the pharynx. This we see in individuals who have stroke, Parkinson's, ALS, myasthenia gravis, head or neck tumors. And then there's esophageal transport dysphagia, which has to do with the typical location is the esophagus. And this is a mechanical obstruction, and this is due to stricture, tumor, eosinophilic esophagitis, sometimes motility disorders like achalasia, scleroderma. And some of your clinical clues would be with the oropharyngeal. This is troubles initiating swallowing, choking, nasal regurgitation, coughing, aspiration, and recurrent pneumonia. Esophageal, often if the individual only takes solids, this is often a mechanical obstruction when you think of stricture or tumor. If it's solids and liquids, it's often a motility disorder. You need to look at a lot of different things. Is this progressive versus intermittent? Is it acute versus chronic? Is there an associated failure to thrive or weight loss? Big red flag, especially with your adults, is unintentional weight loss. If they have pain with swallowing, with systemic symptoms, with fever, night sweats, progressive dysphagia, solids to liquids, regurgitation of blood or food, and then some of the neurological symptoms, aspiration, choking, hoarseness. Important to get a good history and physical. You want to look at the onset, duration, progression. Is it solids versus liquids? Are there associated symptoms? Heartburn, regurgitation, hoarseness. You want to screen and do a good neurological exam as well as a good physical exam, looking for any structural causes. And when you think about some of the diagnostic tests that we would use for individuals with dysphagia, you think about your barium swallow, and this is going to let you know, is this mechanical versus motility? Is there a stricture? Upper endoscopy and EGD. This gives direct visualization. They can do a biopsy, dilate. They also do the video fluoroscopic swallow study. This looks at, you really see the aspiration risk. You can look at the oropharyngeal dysphagia. And then sometimes they'll do a mammometry, which looks for motility disorders. With the elderly, we think about stroke, Parkinson's, dementia, esophageal cancer, and more like your older adults, your elderly. With adults, GERD, is there a stricture, eosinophilic esophagitis, or motility disorder? With kids, where, often it's congenital anomalies, cerebral palsy, it could be a neurological disorder as well. So just to kind of, so a couple things to think about. Solids first and liquids later. Often that's a mechanical obstruction. Solids and liquids from the onset. This is a motility disorder. Oropharyngeal dysphagia often has a neurologic etiology. And if the individual has weight loss, progressive symptoms, or pain with swallowing, you want to do an urgent EGD. You want to always assess aspiration risk. And you'll see that a lot with your stroke scale patients that they bring in. You'll see that they're NPO until they have a swallowing eval. Now, thinking about things that cause dysphagia in kids, if it's a transfer dysphagia, oropharyngeal, again, neurological disorders, cerebral palsy, myasthenia gravis, esophageal, a transport dysphagia. This is usually you'll see in infants or older children. Is this a mechanical obstruction, a stricture, foreign body, or a tumor? Or they can also have a motility disorder that achalasia and GERD. So some of the things we're going to be looking for, we're going to, ask and maybe have the child feed in the office. We're going to be looking for choking, gagging, nasal regurgitation, coughing or cyanosis with feeds is a red flag. If the kid has had recurrent pneumonia or aspiration, this is another red flag. We need to dig a little bit deeper. Poor oral intake as well. And these are especially important to look at with your oropharyngeal dysphagia. With the kids with the esophageal dysphagia, are they having difficulty swallowing solids? Is it now progressing to liquids? Are they having painful swallowing? Are they having regurgitation or vomiting? Big red flag is your weight loss or failure to thrive. So keep that in mind. Again, with the kids, really important to do their history and physical, good neuro exam as well as a good physical exam, taking a good look at the mouth, the nose, all the structures involved. Now, common causes by age. Infants less than a year of age, usually neurologic, it is prematurity, cerebral palsy, hypotonia. Structural, they could have a cleft palate, a laryngeal cleft, esophageal atresia, and you need to think about GERD or a cow's milk protein allergy. With your toddlers and older children, you think about esophageal strictures, achalasia or motility disorders, and behavioral feeding disorders. How are we going to manage this? We're going to try to address the underlying cause, reflux management. They may see GI and actually have dilatation. Feeding modifications, they may do thickened liquids, smaller volumes, upright positioning, and you may send these kids for swallowing therapy. They may need nutritional support of an NG tube or a G tube, and you're going to monitor their growth and weight very, very closely. So again, Oropharyngeal dysphagia. This is often a neurologic or structural cause. Esophageal dysphagia, solids first, then liquids. That often points to an obstruction. Solids and liquids from the onset. This is often a motility disorder. Red flags, your failure to thrive, recurrent aspiration pneumonia, pain with swallowing. Diagnostic choice for the kids is the video fluoroscopy for oropharyngeal and an EGD for esophageal obstruction. You want to refer them. Okay, this is one of these cases where you're probably going to punt them out of the office sooner than later, so you can have the pediatric gastroenterology take a look and help you manage these cases. Vomiting. The definition is forceful emptying of gastric contents. It's one of the most common symptoms of childhood. You want to be clear, and when you think about the etiology of vomiting, oropharynx, this can be a cleft palate or a laryngopharyngeal cleft. Upper GI, it could be a congenital stricture, foreign body, gastritis, esophagitis, pyloric stenosis. Small intestine, they can have intestinal atresias, intestinal malrotation with volvulus. Colon, you think about Hirschsprung's, intussusception, fecal impaction. And with infections, you can have a bacterial enteritis. Kids can vomit with otitis media, sepsis, UTI, viral gastroenteritis, hepatitis. And neurologic causes may be your hydrocephalus, brain tumors, migraine headaches, head trauma. So there's a very, very broad differential diagnosis when you have a child present with vomiting. It could be something as simple as a cow milk protein allergy, but you also even need to think about toxic ingestions, appendicitis. With your adolescence, it could be a pregnancy. So with the history, you want to think about a couple different things. Recent antibiotic use. You're going to go through the family history, past medical history, surgical history. You want to talk about medications, homeopathic and over-the-counter. Have they been exposed to illness? Has there been a head injury or stress for the child at school or at home? You want to think about the relationship of vomiting to the meals, the time of day, activities, and the presence of associated symptoms. Is there diarrhea that goes along with the vomiting? Is there a fever? Are they complaining of ear pain? Have they had a headache? With a kid with a high-pitched cry and seizures, these are big red flags. And do they also have anorexia going along with the vomiting complaint? You're going to make sure that you're going to do a good physical exam for the vomiting child, any of your patients. You want to first and foremost assess for dehydration. You want to look at the growth parameters and vital signs. Good neuro exam, good abdominal exam, respiratory exam. You want to do EENT, especially with the kids. Take a look. You may get a surprise otitis media. And if indicated, you're going to want to do a pelvic exam as well. Some things you might want to consider for diagnosis with the vomiting is you may do some laboratory tests, your CBC, CMT, LFT, ammonia levels, CRP, ESR, amylase lipase, beta HCG, and a toxology screen. You may do a UACNS, a stool for CNS, C. diff, white blood cells, O and P, and fat. You may consider an abdominal radiograph, ultrasound, a barium swallow, endoscopy, a CT, or an MRI. How do we manage vomiting? First of all, you want to determine the degree of dehydration. Is it present or is it not? Often you will have do a little bit of bowel rest, 1 to 2 hours, and then PO, and then rehydrate, PO or RIV, about 20 milliliters per kilogram. You want to avoid solids for 4 to 6 hours and then reintroduce a bland diet, a brat diet. You may use some antiemetics. Zofran is a real popular one. You're going to have the parents monitor the INOs. You may use Reglan. I do want to tell you with the Reglan, you can end up having a patient, they can end up with torticollis, which can be really super scary. So that just keep that in mind too, as you're deciding what you're going to manage your patient with. Cyclic vomiting syndrome. So this is intense vomiting, nausea, vomiting, and retching. It can last hours to days and can vary in intensity. Sometimes these individuals will get a warning phase with intense nausea, sweating, and there really isn't a known cause, but they are finding that there's a strong association with migraine, especially with personal or family history of migraines. What can be some of the triggers? Emotional stress, excitement, infections, menstruation, exhaustion, and cannabis use, and especially in adults and or adolescents. You can get the cannabis hyperemesis. Basically, this is another rule out medication. You're going to have to look at this and, take a look and see, do they meet criteria for the Rome criteria, and how do we treat this? So, some of the things you want to maybe stop and think about, what are some of the triggers. You may recommend lifestyle changes and preventative medications as well. Sometimes Zofran is enough, but even now you're seeing that they're actually using sumatriptan for treatment as well. But what you're trying to do is kind of stop that continuous cycle. And sometimes they will give some prophylactic medications as well, to kind of stop the cycle, stop the vomiting. But again, you want to rule out everything else before you just call it cyclic vomiting syndrome. With adults, interesting enough too, they will present with the vomiting, and they'll say the only thing that makes them feel better is a hot shower. So that can be a little cue to what's going on. When marijuana was first legalized in New York, we had several come into the emergency room, and it was interesting to me because it was just like a free-for-all, the Wild West. They were smoking it all day, all night, and then having this cyclic vomiting that happened. So just something to think about as well. So diving a little bit deeper on how we're going to assess our patients in the clinical practice, one of the first things that you need to really be well versed in are the danger vital signs. Now you're thinking, okay, the ER nurse is like, oh, we've seen this before. So the ESI vital signs, it's important for the outpatient providers to understand as well, because if your vital signs are elevated, this needs to be relayed to the emergency room if you're sending them in, or you need to recognize that something's going on. So on this slide, you can see 0 to 3 months, a heart rate greater than 180, red flag. Respiration rate over 50, red flag. 3 months to 3 years, greater than 160 for a heart rate, greater than 40 for respiration rate. Heart rate 3 to 8 years, greater than 140 and for the heart rate, and greater than 30 for the respiration rate, and greater than 8 years or older, heart rate over 100 is a red flag, as well as respiration rate over 20. Now with dehydration, you can see an elevated heart rate. That might be something you see with your vital signs. You may see a lower blood pressure. And then also keep in mind an SaO2 less than 92% is also considered a red flag. So the first thing you're going to do is look at your patient's vital signs. Just because you're an NP now doesn't mean that you don't have to take a look at them, and you may want to take a set of your own if one is elevated when you're looking at your patient. The next thing you're going to need to look at is the dehydration clinical observation scale. And on this slide, you can see there's different clinical signs that present with mild dehydration, moderate dehydration, and severe dehydration. So if for someone who has mild dehydration, the weight loss will be 3 to 5%. Behavior will be normal. They'll be slightly thirsty. Mucosa is the membranes may be normal. Anterior fontanelle is going to be flat. Eyes will appear to be normal. Skin turgor normal. Blood pressure normal. Heart rate is normal as well. Urine output may be decreased. With moderate dehydration, you may see a weight loss percentage of 6 to 9%. They may be normal to listless. Thirst is moderate. Mucous membranes are dry. Anterior fontanelle is sunken. Eyes sunken. Skin turgor is decreased. Blood pressure is normal. Heart rate is increased. Okay, so you go back to those vital signs. And your urine output is markedly decreased. So you're going to ask the mother, since the child's had X, Y, and Z, today, how many wet diapers have they had? How many did they have yesterday? With severe dehydration, you're going to see greater than or equal to 10% weight loss. Behavior with a patient with severe dehydration is normal to lethargic or comatose. They may have intense thirst. Mucous membranes are going to be dry. Anterior fontanelle will be sunken. Eyes will be deeply sunken. Skin turgor is decreased. Blood pressure may be normal to decreased, and the heart rate will be increased. And at this point, with severe dehydration, the urine output is basically null and void anuria. So make sure you take a look at the dehydration clinical observation scale. Pyloric stenosis. This usually develops between 3 and 5 weeks. It rarely occurs after 12 weeks of age, and this will be a child, the mother will say that they're having projectile vomiting. If on an exam, when you palpate the abdomen, you may feel a olive-shaped mass in the right upper quadrant, often after feeding, because the stomach is trying to push the contents through a narrowed pylorus that can be problematic. Obviously, it's going to be it's going to be painless, this mass that you feel. What are some of the things that are associated with pyloric stenosis? Male sex, preterm birth, firstborn, and younger maternal age. These kids are going to, the mother is going to present with you, and it's really forceful, like they're going to hit the wall, projectile vomiting, because the vomiting will go several feet. It's often non-bilious, not green, it's not yellow. It's right after they eat. One of the key things to keep in mind too is that these kids are constantly hungry. Especially right after they vomit. You're gonna really want to look at that dehydration observation score with them, because it's a red flag if they're crying without tears, they're having fewer wet or soiled diapers, if they're losing weight, failure to thrive. You may even see visible stomach contractions, like wavy ripples across the belly may be seen before vomiting. And this is often diagnosed through physical exam. They'll do an ultrasound looking for a thickened pyloric muscle. Often to treat this, it's a pylorotomy, where they actually cut the thickened muscle, allowing the food to pass. So keep those things in mind for pyloric stenosis. Gastroesophageal reflux. This, the etiology is unclear. It can be multifactorial. You're going to want to make sure you take a good history, the birth, the medical, the social history. Is there any concerns about their feeding? Has there been failure to thrive? You may want to do a 24-hour history with the mother. Often with GERD, you're going to see early morning emesis. That's something that the parent will present for the infants and children. With kids, you're going to be looking for failure to thrive on a physical exam. Do they have torticollis? Is there a hoarseness of the voice? Are they, when you look at their blood work, are they anemic? Has there been tooth eruption? Do they have a rash? Again, you're going to do some diagnostic tests, CBC with differential CMP, UA, CNS. You may do an abdominal ultrasound, especially in your young infants, to rule out pyloric stenosis. They may get an upper GI series, an endoscopy to rule out esophagitis. They often will do esophageal pH monitoring, and this is reliable for diagnosis as well. How do we manage this? With breastfed infants, they should continue to breastfeed. Formula-fed infants, you may do a 2-week trial of hyperallergenic formula. You may do prone positioning for infants. but there are risks versus benefits due to SIDS. With older children, you want to avoid chocolate, caffeine, spicy foods, high-fat foods. Beach children, you're going to encourage activity, healthy diet, and weight loss. You want to follow the growth patterns with these kids really closely. Now, in severe cases of esophageal reflux, the child may have a Nissen fundoplication, and obviously we're going to use some medications, H2 receptor antagonists or your PPIs. Peptic ulcer disease in pediatrics occurs in a small percentage, about 1 to 2% of children. You think about, just like with the adults, primary ulcers tend to be duodenal and chronic in nature. Secondary ulcers are often associated with ulcerative events, your H. pylori, stressful situations. Your kids, sometimes they'll be in the burn unit. If they are on chronic oral steroids. With your older adolescents, smoking and alcohol are all associated with ulcers. We know that. We want to make sure that we look at the family history and be more aggressive, obviously, if there's a history of gastric cancer. With your little ones, you want to make sure that you are looking at the feeding history. They may be asymptomatic. Older children may have pain with eating or pain that awakens them from sleep. You want to be vigilant about any blood in the stool, black stools. With peptic ulcer disease, again, good history, good physical exam. You want to make sure you're doing a careful exam of the mouth, the abdominal exam. You may need to do a rectal exam as well. Sometimes we will use diagnostics, CBC, ESR, CMP, including the LFTs. You may check the stool for OMP, blood and culture. You also may do a serum IgG antibody for H. pylori. And, if the child is positive for H. pylori, we do treat it. And, basically you're going to be looking at your region, and is there clarithromycin resistance in that area. So if it is known that it is clarithromycin resistant or unknown, you're going to use the bismuth based quadruple therapy. So that's bismuth, PPI, amoxicillin, and metronidazole. Okay, your flagyl. Okay, if they're less than 8 years of age. If they are over 8 years of age, you're going to use bismuth, PPI, your flagyl, and with the difference with this one, over the age of 8, you're going to add that tetracycline. So if you do have the clarithromycin, it's susceptible, you would do a PPI, amoxicillin, and clarithromycin. In the event that they're pen allergic, you're going to use a PPI, your flagyl, and you're going to use clarithromycin. Okay, so that one works out really well. The PPI, the flagyl, and the clarithromycin if they're pen allergic. So keep that in mind with peptic ulcer disease. We do treat kids for that. In regards to pediatrics and abdominal pain, you can have a really broad differential diagnosis. Some GI causes, gastroenteritis, appendicitis. Those of you who work in the ER, you've probably seen come up on your CAT scan. The kid walked in, you thought for sure it was appendicitis, and when the CAT scan came back, it said mesenteric lymphadenitis. So that's basically secondary to a virus where the lymph nodes are enlarged in the abdomen that can really sometimes mimic other abdominal pain causes. Abdominal trauma, we talked a little bit about it's really important that in your physical exam that you're taking a look at the actual skin of the abdomen, because Sometimes, obviously the kids, if they've fallen on their bike, they may not have thought it was a big deal, but often when kids fall on the bike, the handlebar can get jammed into that left upper quadrant and they can have a splenic rupture. So it's important to take a look at that area for sure. So that splenic infarction, rupture of the spleen, that's a real deal. Or they've fallen out of the tree and they don't want to tell their parents, etc. GU causes, genital urinary, UTI. These kids can have kidney stones. In your female adolescents, they can have dysmenorrhea, mental smirts, and they're sexually active. They can have pelvic inflammatory disease as well. Kids with diabetes, diabetic ketoacidosis, with your hematological disorders like sickle cell, they can present with abdominal pain as well. Your littler kids, lead poisoning, and you think about some of the other things that we've talked about already, the colic, the dysphagia, these type of things. It can be an intussusception as well when you think about that. But the most common cause for abdominal surgery in children is appendicitis, and we'll talk about that on the next slide. Appendicitis is the most common cause of abdominal surgery in children. It's most frequently seen in adolescent boys. What is the typical history? Anorexia for 12 to 24 hours, child not acting right per the parents. They may have nausea and vomiting. They may have a gradual development of diffuse abdominal pain or cramps. Often it'll start in the periumbilical area and then eventually localized in the right lower quadrant at that McBurney's point. Displaced appendix is common, so the pain may not be in the right lower quadrant. And keep in mind that pain is often a late symptom. Like I talked about earlier, acute appendicitis is one of the most common causes of abdominal pain and the most frequent condition that leads to emergent abdominal surgery in kids. So keep that in mind. Keep in mind too, fever is a late sign. You may have difficulty differentiating between gastroenteritis because sometimes the symptoms are often identical. But the thing to keep in mind is rebound tenderness is specific for appendicitis. Their white blood count may be elevated. Often you may start with the kids with an ultrasound. If that's inconclusive, move on to a CAT scan. And keep in mind too, if you have absent bowel sounds, this may indicate appendiceal rupture or peritonitis. Intussusception. Intussusception is a serious problem with the intestine or the bowel. And when this occurs, part of the intestine collapses onto itself. It folds into itself kind of like a collapsible tube, like an antenna for a radio, kind of folds up together, with one part slipping inside another part. And this makes the intestines not work properly, obviously. What are some of the causes? They can have GI polyps, Meckel's diverticulum, constipation. Rotavirus is a common cause, foreign bodies, cystic fibrosis. And the child's often going to present with paroxysmal episodic vomiting every 5 to 30 minutes. The kid's screaming, drawing the legs up to the chest. They may be lethargic. They may have red currant jelly stools. Ding, ding, ding. That's a big red flag for intussusception. You can see that in the boards and the wards. Fever, and this often may follow a bout of gastroenteritis. On physical exam, you may feel like a sausage-like mass in the right upper quadrant. This is called Danca's sign, DANCA''S sign, and the abdomen may be distended. What do we do for these kids? Often a surgical consult. And what I found in the emergency room, what they will say is they'll order the barium enema, and that often will correct the problem. With these kids, you're going to want to check a CBC and CMP. You're going to rehydrate, and if it isn't resolved with the barium enema, these kids will often go to the OR for correction. Foreign body obstruction. This is really pretty common. There's more than 100,000 cases of foreign body ingestion in children reported each year in the United States. It's something you probably will see. Most of the kids, it's ages 6 months to 3 years, so they're usually younger children. What are some of the things that kids will ingest? Coins. Now that we use cashless payments, we see that is a little bit less common. One of the big ones that's important to kind of talk about is the disc or button batteries. And now they've got some like safeguards put on because they can end up with an esophageal burn, a perforation, or a fistula. So it's important that, if that's something that happened, they came to the office, that's not something you're going to wait to pass. They need to go to the emergency room because they may need to have that endoscopically removed. The other thing that kids sometimes will ingest are sharp objects, straight pins, needles, straightened paper clips. And, that's something to think about as well for safety issues. Magnets, that can be a problem too. There are, some warnings on the toys now, especially if a child's had more than one magnet that they've ingested. This can really wreak havoc and, be problematic. So these are things you're not going to be handling in the office anyway, if they have something that is not going to pass easily. So often when you have the kid come in, that the parents have said they ingested X, Y, and Z, you may do an x-ray, and if a child has an esophageal foreign body, they may be asymptomatic or they may present with refusal to eat, dysphagia, drooling, or respiratory symptoms, even, stridor, choking. This is a big red flag. So often we will do an upper GI, a flat plate to kind of see whereabouts the object is. And if the object has reached the stomach, and that's usually, they usually are asymptomatic, and we will let that go. But sometimes you'll see that foreign body is sitting above the valves of the stomach and they're not going to pass. So that's the case. They often will have to have an endoscopy for removal. So basically for all patients with suspected foreign body ingestion, the initial diagnostic test should be a biplane radiograph. So it's a flat plate, anterior, posterior, and lateral. And you're going to want to do the neck, the chest, and the abdomen. So when they're 6 months to 3 years, you can often get that in one shot. Now keep in mind that if whatever they swallowed is made of wood, some thin metal objects, and some types of bones, they are easily seen on a conventional radiograph. So just keep that in mind. So you want to make sure when you're looking, is it in the esophagus versus the tracheal? Your coins are just batteries in the esophagus, usually orient in the coronal plane and appear circular object in the anterior posterior projection, whereas objects lodged in the trachea tend to orient in the sagittal plane and are best seen in the lateral projection. So you're going to want to have two views. They always say that two views is one view. Two views is, I don't know, how does that go? One view is too few, so you usually want to have two views, AP and lateral. It may be difficult to differentiate between a disc battery and a coin on the radiograph, and that can be problematic too if you're not able to see what's going on with the kid. Indications for urgent removal when the patient's showing signs of airway compromise, obviously. If there's evidence of near complete esophageal obstruction, they can't swallow secretions or they're drooling. If the ingested object is sharp, if it's a high-powered magnet or coin battery, okay, because we talked about some of the things. So for patients without any of those characteristics, usually observation for 12 to 24 hours is reasonable because they can often have spontaneous passage. And they have seen that, especially with esophageal past coins that the kids have swallowed, that they spontaneously will pass that foreign body. So that's something to think about too. But yeah, the kids will do some really interesting things. So, but you want to make sure that, obviously if you don't have x-ray in your office, this is a kid that's going to need to go to the ER to have those exams. And if they report when you're on call or in the office that it was a magnet or a coin battery, this is also a red flag that needs to be sent to the emergency sooner than later. Hirschsprung is usually a congenital disorder, and with these kids, they will have an absence of the ganglion cells in the distal colon, which can cause a functional obstruction. The area that's most commonly affected is the rectosigmoid, and what happens is that there's a failure of relaxation and bowel motility. So we see this in 1 in 5,000 births, more males than females. And keep in mind that in about 10% of the cases of children with Down syndrome, they will have Hirschsprung disease as well. So one of the things with the neonates, you may see a delayed passage of meconium more than 48 hours. They may have abdominal distension, bilious vomiting, feeding intolerance. They may see enterocolitis, and this would be kind of a trinity of fever, diarrhea, and lethargy. This is a kid that needs to get seen sooner than later in a place where they can have diagnostics done urgently. In infants and children, these are kids that may have chronic constipation. They may present, mother will say that they're having ribbon-like stools, abdominal distension, failure to thrive. Sometimes they'll have diarrhea again if they have the enterocolitis that develops. So keep in mind, any infant that has delayed meconium passage in a term infant, you want to think Hirschsprung's. We know that enterocolitis is a potentially life-threatening complication and that it's associated with Down syndrome. How do we diagnose? Often on an x-ray, you're going to see a dilated proximal colon and a collapsed distal segment. It's not diagnostic, but this is supportive. You may, a contrast enema may be done, and the sensitivity on these does vary with age, but the finding that you would expect to see is a transition zone, narrow distal, dilated proximal. Rectal biopsy, this is the gold standard. So often what they'll do is a suction biopsy, and this will confirm the absence of ganglion cells. And they may also do acetylcholinesterase staining as well. And they may do an anorectal mammometry, and this would, we expect to see a lack of recto-anal inhibitory reflex, and that's a screening tool for older infants and children, but again, it's not definitive in neonates. And how do we manage this? What they do is, it's called a pull-through procedure, and what they do is they remove the area of the bowel that does not have any of the ganglion cells. So we talked about some complications. The enterocolitis, that's the most serious complication that can happen in 30 to 40% of cases. So the child has Hirschsprung's, they're waiting for surgery. You're going to be on the lookout for that. These kids may have chronic constipation post-surgery. They may have fecal incontinence. They may have strictures or obstructions secondary to the surgical site. So once again, Hirschsprung's, newborn with delayed meconium passage and abdominal distension. It's Hirschsprung's until proven otherwise. Down syndrome and chronic constipation, you want to screen for Hirschsprung's. Rectal biopsy is the definitive diagnosis. And the only treatment that's definitive is surgical intervention. And you want to avoid rectal medications that are used alone. Encopresis. This is the repeated involuntary leakage or passage of stool into clothes in children over the age of 4. It's often linked to chronic constipation, This is, it has to occur once a month for greater than 3 months, and it's, again, the child that's 4 or older. Prevalence is about 1 to 3% of school-age children, boys more than girls. There's a couple different types. There's retentive encopresis, which is most common. This is secondary to chronic constipation and fecal impaction. And what happens in this case, the stool leaks around the impacted mass. Then there's non-retentive encopresis. These are as a child that has normal bowel habits, and it's usually behavioral or psychological. What are some of the causes and risk factors? Chronic constipation that we talked about, that's the most common. Stool withholding, painful defecation, often happens in kids. They have a low fiber diet. It can happen secondary to psychological stressors, school anxiety, family stress, and it can be also risk factors, neurodevelopmental disorders, your ADHD, your autism. What does this look like clinically? We talked about the child's going to have large hard stools intermittently with soiling of underwear. They'll have abdominal pain or distension, avoidance of the toilet. Rarely you'll see blood in the stool unless there's a fissure, and the normal growth is usually preserved, so there's no failure to thrive in these kids. You want to do a thorough history, physical exam. You may do a rectal exam where you're going to have palpable stool in the rectum. What are some red flags for organic disease? If there's a history of delayed meconium passage, failure to thrive, bloody stool not associated with fissures, and neurological deficits. Okay. How do you manage it? Step one usually is a disimpaction, either oral or rectal therapy. So you may use polyethylene, glycol, lactulose enemas. Maintenance therapy may be daily laxatives, your PEG, your lactulose, and to prevent any reimpaction. And then adequate fiber intake, making sure that the child has adequate fruits, vegetables, and whole grains, and adequate fluid intake as well. You may do some behavioral toilet training. You may have the parents schedule toilet sits, so 5 to 10 minutes after meals. They may use positive reinforcement and reward system, and you're going to do a lot of education with the child and the parents. So just to recap, most encopresis is secondary to chronic constipation. There's retentive type versus non-retentive, and you're going to see more of the retentive type versus non-retentive in the cases that you'll see. You want to rule out organic causes if there's any red flags that are present. Treatment is disimpaction and maintenance with behavioral intervention, and early intervention often prevents psychological and social complications. Toilet refusal syndrome, TRS. This is also called stool withholding or encopresis that we just talked about. So a past painful bowel movement due to constipation, diarrhea, or diaper rash can make the child have a fear of pooping again. They may have control or power issues. It can be anxiety, stress, new school, new sibling, divorce, and it may be just a habit that they prefer the comfort of a diaper, not willing to give up the baby habits. So in the TRS, this is when a child, often after successful potty training, that's why it's over 4 years of age, refuses to defecate in the toilet, preferring diapers, leading to constipation, accidents, and distress. So keep that in mind. If you see toilet refusal syndrome, it's a fancy name for encopresis or stool withholding. Diarrhea. Diarrhea is defined as either watery stool or increased frequency or both when compared to a normal amount that the patient usually encounters. It's usually a common problem that lasts a few days and disappears on its own. Now in acute, it's a short term, lasting less than 2 weeks. It's usually related to bacterial or viral infections. Chronic, it's more long-term, lasting more than 2 weeks, is usually related to a functional disorder such as your irritable bowel syndrome, or maybe related to disorders that your patient may have, like ulcerative colitis, Crohn's, celiac, or giardia. Now, like we talked about, it can be a bacterial infection, a viral infection, it can be a functional disorder, it can be secondary to a medication and or stress. History is imperative for you to take a good look at, and when you do your physical exam, you're going to do a good abdominal assessment. You're going to look at the mucous membranes. Is this patient dehydrated or not? They may report to you that they're having cramping, abdominal pain, an urgent need to use the restroom, a fever, or bloody stools. So these are things you may see. What are some of those warning signs of severe diarrhea? Severe abdominal pain, blood in the stool, frequent vomiting accompanying the diarrhea, loss of appetite for liquids, high fever, signs and symptoms of dehydration, weight loss, and in your kids that are younger, if they are having fewer than 6 diapers per day, or no tears when crying, that's also a big red flag. Keep in mind that worldwide, diarrhea is a major cause of infant mortality, especially in your developing countries. Primarily viral or bacterial, most commonly viral, usually due to rotavirus or adenoviruses. And bacterial pathogens are usually C. difficile, Salmonella, Giardia, or Campylobacter. Always serious in infancy due to the how quickly a young infant can dehydrate. So you really want to make sure that you're doing a good assessment. C. difficile, we know this can happen, and the most common antibiotics implicated in C. diff colitis are cephalosporins, especially the second and third generation, and your ampicillin, amoxicillin, and clindamycin. And you often are going to be prescribing these to kids. So keep that in mind too. You want to ask about any antibiotic use, and especially in this day and age where people are a little bit transient, where they may see you in the primary care office, they may do telehealth for another ear infection, or urgent care ERs, and not all the systems are connected. So these kids may be on prolonged antibiotic use, especially the use of 2 or more antibiotics does increase the risk of disease. So keep that in mind, C. difficile as one of your differentials for diarrhea. Now keep in mind, rotavirus diarrhea, this is the most common cause of severe dehydrating diarrhea. We know now there is a vaccine. This you're going to see, this accounts for about 500,000 office visits yearly and about 50,000 hospitalizations in children less than 5 years of age. And by the time a child is 5 years of age, almost all children have had rotavirus at least once. What is their prevention? Primary prevention is breastfeed for at least 6 months to get antibody protection from the mother, and then we do have that vaccine that's available as well. We've talked a lot about failure to thrive, and in pediatrics, this is important. So when you do your pediatric rotations or your primary care rotations, what you're going to see is they're going to do the height, the weight. With the kids, they're going to do the head circumference, and they're looking at growth patterns, right? So in failure to thrive, this is when a child or a baby isn't growing or gaining weight as expected for their age. So what you're going to see is that they are below the 5th percentile on growth charts. And this often can happen if they're not getting enough nutrients, absorbing them properly, or there's an underlying medical issue. So keep that in mind. I know I've been talking about failure to thrive, and I just want to be clear that you understand what that means. Common causes, again, inadequate nutrition, absorption problems, medical conditions, it could be numerous things. It could be environmental, social factors. It could be neglect, poverty, parental mental health issues, poor parent-child bonding. It could be developmental issues. When we talked about dysphagia earlier, it could be a child that has on the autistic spectrum who has sensory issues. So keep that in mind. I just want to be clear that you understand what failure to thrive is. Pediatric malabsorption syndromes, these are disorders that prevent children from absorbing nutrients. And sometimes they have symptoms like chronic diarrhea, foul-smelling stools, bloating, weight loss, failure to thrive, and developmental delays. So when I talk about some of the disorders that can cause this, it's celiac disease, cystic fibrosis, Crohn's. They can have lactose intolerance as well. So those are some of the things that you would be looking for. With malabsorption syndromes, you're going to be looking for the root cause, okay? Because often, for example, following a special diet like gluten-free for celiac, that can help. For kids that have pancreatic issues, they may do enzymatic supplements, and they may need additional vitamins, supplements, or medications for inflammation or infection. If you think about Crohn's, obviously we're going to be, treating that. When you think about celiac disease, gluten damages the small intestine. So they end up having malabsorption. Cystic fibrosis, there's thick mucus that blocks digestive enzyme flow. Crohn's disease, they have inflammation to the bowel that affects the gut lining that causes malabsorption. Lactose intolerance, this is an inability to digest the milk sugar. So these are all some examples for you to think about with malabsorption syndromes. So in this slide, the picture on it is actually what gluten looks like under a microscope. So celiac disease, this is a inflammatory process often that can be hereditary. And with these individuals, there's chronic malabsorption syndrome due to a sensitivity to the gluten protein found in grains. So that's wheat, barley, rye, oats. Patients can usually eat corn, sometimes rice. And when children with celiac disease ingest, grains that have gluten, they end up having changes that occur in the intestinal mucosa or the villi that prevent absorption of foods across the intestinal villi into the bloodstream. So what you're going to see with these kids is that they're going to have malabsorption related to their inability to absorb fat. So how is celiac going to manifest? They're going to have steatorrhea, okay, fatty stool, greasy stools, vitamin deficiencies in A, D, E, and K, malnutrition. They may have distended abdomen with skinny extremities. They may have irritability, anorexia, the failure to thrive, growth failure. They also may develop rickets due to vitamin D deficiency and clotting disorders related to vitamin K deficiency. It's, I think that it's more prevalent now because there's so many more choices that are available to people. We see it, in the grocery stores. We see it on menus, gluten-free options, this type of thing. With celiac, it's a dominant inheritance in children of Northern European descent. And what is the treatment? Gluten-free diet for life. And thank God now there's way many choices than there were in the past. And to finish up our lecture on pediatric GI, it wouldn't be complete without talking about helminths, intestinal parasites. So one of the things you may have to think about, especially in the summertime, or if you're taking care of somebody perhaps that does not have running water, they're homeless, is Giardia lamblia. This is a protozoan that's found in contaminated water. The patient will often present with diarrhea. And then we've got pinworms, Enterobus vermicularis. Pinworms, they are easily transmitted in families in daycare. They can survive in bedding and clothing, and often the child will have incessant perirectal itching or vaginal itching. And one of the things that healthcare providers do is a tape test, and if you can, you try to perform the test first thing in the morning before bathing or using the toilet. And so keep in mind, itching can be worse at night or in the morning because the pinworms lay their eggs at night around the anal area. So you're going to use a piece of clear tape and about 4 to 5 inches long, and you're going to hold the tape with the sticky side facing the anus. You're going to wear your gloves. You're going to press the tape on the skin around the anus for a few seconds, and this will collect the pinworm eggs. And then you'll be able to fold the tape in half so the kind of sticky sides stick on one another, and you send it in a specimen container to the lab. Then there's roundworms, and I can honestly say that I've had the pleasure of seeing one in live and in living color in practice, and it was kind of sad. The poor mother came in, and I guess they were eating spaghetti for dinner, and when she changed her baby's diaper, she saw this piece of what she thought was spaghetti. She thought was odd, and then she saw that it was moving. So she brought it to me in a Cool Whip container, and sure enough, it was a roundworm that was about 4 inches long. It was white. If you're not washing your vegetables from the market, we're all at risk for it. So often with pinworms, you'll see the worms in the stool or the vomit. In this case, it was the stool. Then there's tapeworms, Taenia, and these are from contaminated beef or pork. And this would be that the patient presents, they have worms in their stool, they may have abdominal pain or an excessive appetite. So a lot of times, if you've had international travel, this is something to think about as well. How do we treat it? With Giardia, we often will give flagyl. With pinworms and roundworms, we use mebendazole, and that's usually one-time dose, and then repeat in 2 weeks for the pinworms. For the roundworms, you're going to give it for 3 days. And then with the tapeworms, we're going to also use a similar type of medications, and that would be, usually that is praziquantel, 20 milligrams per kilograms per day in 4 divided doses for 1 day. So yes, you can have some creepy crawlies as well with your kids. You think about, they are in daycare, especially your 3 and 4 year olds. They don't often have, unless they're prompted, to wash their hands well. They're into everything, touching everything. So it can be, it isn't uncommon to see some of these helminths in your practice. I hope you enjoyed this lecture. That's the end of the Pediatric GI series.